Can I ask the panelists, hey, this is Jeff Rowe. Can I ask the panelists that do endoscopic spine surgery? So there are different techniques, right? So you can use one scope, you can use the UBE with 2 portals, you can do transforaminal, you can use the interlaminar. So how do you guys sort of end up gravitating towards your own particular style of doing endoscopic spine surgery? And I'd love to hear from, especially from Luke and Harrison as well.
Okay. Before asking us. So we have the different skill set. Discectomy through the foramen, through the interlaminar, sometimes transforaminal. Other guys love to do bipolar endoscopic spine surgery. And yes, we have the various kind of weapon for treating the patients. I feel like the endoscopic surgeons looks like the artist, because you guys know the patient have, even though the single level disc prolapse, the type and the extrusion, the symptoms and the degree of the extrusions, location of spinal stenosis is quite very difficult, because the endoscopic surgery is target-oriented spine surgery. We don't have to open up all the structures, so we always focus the main, what gonna be the main symptoms, what gonna be the main tackles we have to solve. So that's why I love to say the endosurgeons like the artists of drawing, the artists. So it's true. So many of the endoscopic guys, they have this talent of the drawing and pictures, take a picture and drawing, and they love the music. Anyways, it's a different talk. So treating the patient with the spinal stenosis, we have, for example, some guys full endoscopic surgery, like the Harrisons, and the different guys, they love the bipolar surgery. I have done also a couple of cases, more than 30 cases bipolar, even the fusion surgery. Personally, I believe in the simple spinal stenosis, one-level spinal stenosis, and the kind of sort of the disc herniation. So full endoscopic surgery is gonna be enough. We can cover we can do the surgery in most cases of the single-level spinal stenosis and the disc herniation. But I feel in the case the instability which need the fusion surgery, bipolar works. Yeah, bipolar. But except I don't know the Harrison love to talk about because he had the excellent result of the full endoscopic fusion surgery as well. But his skill level is not the human level. His skill level is the Master Jedi. Yeah. So I don't like to say that don't follow. I don't like to say follow the Harrison, because his level is not the human level, right? Okay, that's my personal opinion.
Thank you for a comment, Dr. Loke. But I think that maybe with there may be some different technique, but I think that maybe it we are similar, and conclusionally it may be some same to purpose of the endoscopic surgeon's purpose to treat the patient. Actually, can divide it only uniportal and biportal. And also treatment method also some different. I think that may depend on the surgeon's philosophy, like some Western pattern and Eastern pattern is completely different. Like Korea culture and some Western culture is completely different. Because of that, maybe it divided, seems like some different kind of approach and techniques. But in conclusionally, I think that maybe it's all same of the endoscopic spine surgery for treating the patient.
If I can chime in, I would agree with that. I think there's different variations of the endoscopic technique, but the biggest leap is using the endoscope, which is a two-dimensional visualization where you have to picture a three-dimensional anatomy underwater and greatly magnified, with whether you use a dual portal or uniportal, you don't have the leeway of open surgery to make all these angles. You have to be very precise in your angulation. So you're constantly having to redirect where your mind is picturing the three-dimensional anatomy as you move from one section to the other. That's where the confusion comes from. So whether you go intradiscal, extradiscal, interlaminar, biportal, or uniportal, my guess is that the first leap is getting used to that two-dimensional underwater magnified view with very limited ability to angulate your instrument.
I've done a little over like 20 cases, and I agree with BK. Like when you first put your scope in there, you just feel like, where am I, right? So that part is very disorienting, you know. But it's great to see that like masters like Chol and Luke and Harrison, and then now seeing that BK is actually adopting this, it's really makes me feel good about that. You guys are saying that it's legit.
If I can do it, you can do it.
Thanks, BK.
Once you taste honey, you cannot go back to sugar.
Thanks, guys.
Well, thanks everyone for attending the non-CME session for Eloquence, and thank you to Eloquence for supporting this meeting. They've been doing it every year. So, the Koreans from Korea are the #1 endoscopic surgeons, so it's a perfect fit. We have to kind of carry that torch on the mainland, I guess.